burns. Talking about burns. So, different information about burns as a whole. One, skin and lungs are the first things that we think about. Skin and lungs go hand in hand. The second thing we worry about is mechanism of injury. What caused the burn? What type of burn was it? So that leads us into the different types of burns or classifications. One is a thermal burn. Thermal burns meaning from anything like a flame, hot tar, hot liquid, steam. Thermal burns. Two is chemical burns. Chemical burns come from a strong acid, alkalis, or organic compounds. And then also includes anything that's in the industry, agricultural, or household cleaners. So that falls under that chemical burn. When we're talking about electrical burns, it's heat through an electrical current. It's heat through an electrical current for the electrical burns. Next is radiation burns. Radiation burns have to come from a radioactive source. One radioactive source is, of course, the sun. Distance from the source matters, and dose dependent. How long was that person exposed to that radiation? Dose dependent also leads to fevers, blood dyscrasias, white blood cells are affected, red blood cells, so CBC monitoring, nausea, vomiting, and diarrhea. So dose dependent with that. And then the fifth one is inhalation or inhaling. And that's when patients inhale CO2, I lied, CO, carbon monoxide. So it's from the smoke from flames. 7 times increase in death. First thing we think about is airway. Airway. And then the reason why is chemical actions of the lung tissue occur. So increased respiratory rates, restless, but their pulse ox very well can be 99%. So when we have restless when it comes to airway, we know that it's hypoxemia, right? So the oxygen levels in the blood are decreased. But the pulse ox is going to give you a false reading of 99% or around that. So increased respiratory rate and restlessness. Most burns occur at home, in the home itself. And then this is a very good bullet to remember. Nurses roll in, which equals oxygen. So keep that in mind. Oxygen. So one thing I want to mention a little bit more in depth with electrical burns. So going back to our third type. With electrical burns, one we have to keep in mind about the electrical, where electrical or electricity is located. A lot of them are high wires, right? And so patients develop or have an electrical burn, their chances of falling increase because of where all the electrical is located, right? High wires. So with that said, it becomes a fall potential. And so we have to make sure we protect that C-spine. C-spine's protected. If you have no C-spine, no brainstem, you have no vital signs, no patient. And so we have to make sure that that C-spine is protected. And then, when it comes to the electrical burn itself, what is the extent of injury? And there's 5 things that we have to consider when it talks about, or when we have a patient with electrical burns. One is duration of contact. So how long was that patient exposed to that electrical current? The intensity of that current, as we know, is voltage. So the intensity of that current, intensity. Type of current, was it a direct contact or alternating? Number 4, not the last thing yet. Number 4 is the pathway of current. What path did it take? It's just like a gunshot wound. we always look for an entrance and an exit. Okay? Always. Entrance and exit. Because it ricochets off organs, does more damage. So we look for an in and an out. So, for example, you know Jim's a welder, right? And he has to test electrical currents. He didn't realize that when he was checking it, his belt buckle was on the table. And so when he got shocked, it went and had a sore next to his belt buckle where it would be at, and it came out his wrist. And it looked like a cigar burn, and he doesn't smoke. So you have to find an in and an out. So that's just letting you know about the pathway of current. Number 5 is the resistance of tissues. The resistance of tissues to that electrical burn that passes through the body. So resistance of tissue as that electrical current passes through the body. So with the volts, 40 or more volts, potentially dangerous, potentially cardiac dysrhythmias can occur. Increase in 100 volts or higher, that is extensive tissue damage to patients. So 100 or greater is extensive tissue damage. So goals, of course, is prevention and the mechanism of injury and what type of burn it is. So goals are to get that mechanism to stop and then to start treating. So the classifications of burns with a degree of injury is associated with this. So I like this visual because it gives you the words plus it gives you the first degree, second degree, and third degree. So first degree is superficial, painful, and appears red. So superficial, painful, and appears red can heal on its own within 3 to 7 days. Example could be mild exposure to heat, sunburn. So first degree. Keep in mind, we always think about cap refill. Cap refill. Yes, sir. 3 to 7 days. You're welcome. So cap refill. Second degree are wet, blistered, and extremely painful. So wet, blistered, and extremely painful can heal on its own. It's going to take longer than what we said earlier for the first degree. And it will not require a skin graft unless it's big and becomes infected. So we really want it to stay clean, dry, free from infection, because of course the healing process would be better for that patient. So pain, pain, pain in second degree. Third degree is full damage to the entire epidermis and dermis, as you can see here in this picture. It is usually dry, may become mottled black, brown, white, or red. Same colors as what our melanoma was. Eschar tissue will form from the burnt tissue. Now the pain that they will experience is not necessarily the burn itself, it's those nerve endings around it, right? Because that tissue's gone. It's going to be those nerve endings that have been exposed to the area. But that surrounding tissue is going to be painful. So, determining the depth. How did it occur? What was the cause? What are those 5 types that we mentioned? Did they inhale it? Did they expose to it from a hot? Was it deeper sunburn? And then the causative agent. And then the rule of 9s is a controversy thing. Some places are still bringing it up, and so you know what it is. We're still going to bring it up. So when you're looking at the patient, the head is 9%. Each arm is 9%. Anterior part of the torso is 18%. Posterior is 18%. The leg is 18% each one. And then the genitalia is an exception to that rule, which is 9%. Or 1%. So that is the total body area. So when location is determined where the burn is located, then we give it that percentage or that rule of 9 scenario. Based on location. So, like I said, there's controversy if we use it, if we don't use it, that has come up in evidence-based practice. So, the pathology, or I should say, pathophysiology of the burns, we mentioned already, just keeping those in mind. One thing we mentioned when we talked about shifting, fluid shifting, third spacing, right? The fluid shifts. The patient is hypovolemic because the fluid shifts into those interstitial spaces. So when we're looking at the patient, we're looking at pulmonary injuries, renal, GI, all of these systems play a role in major burn injuries. We need to get that urinary output 30, which is our normal 30 mLs per hour, to at least 50 mLs per hour, or in that range, because we want them to get that fluid back on board. So wound care. Wound care becomes, we want to hydrate them, get them back. Now keep in mind, when we're giving them fluids, they're going to become hypothermic. So we want to keep them warm, right? The spot of the burn itself, we need to get rid of that causative agent, whatever that was. Whether it was steam, heat, whatever it was. And then we want to make sure that that wound is flushed, which hydrotherapy, so that's where the hydrotherapy is. Sterile, it's got to be sterile. Keeping in mind, there's also something else besides first degree, second degree, third degree. The superficial, the partial thickness, the full thickness. There's also something called degloving also, where the skin is completely removed and it looks like wax falling off the skeleton. Horrible, painful, of course, for that patient. Patient, when I was working, patient was at, then it was middle, and he was doing the malted metal, and the, I'm going to say bucket, broke a cable, and it poured on his thighs and his hands. He was only 58. He died about 3 days later from infection, but that 10 milligrams of, back then we didn't use fentanyl like that, but that would have been probably the better drug of choice. But Dilaudid wasn't touching him every 10 minutes, 10 milligrams. So he ended up getting airlifted, and he just succumbed to the infection. But so long story short, keeping them warm, but also getting rid of that causative is the idea. Keeping it as sterile as possible and as clean as possible that we can to prevent that infection. So if it's warranted topical agents that is also a debriding agent, do we know what that debriding agent would be called? Do we know? You're smiling, Haley. Do you know or have no idea? Maybe you do. Maybe that's a question.
I mean, at clinical we use BASH, like BASH wash or solution. We use
Solution,
that.
yes.
That is reading something.
Yes, because it's a wash.
Yeah.
But this is something we put on, especially first degree and second degrees, to help debride. Huh? I hear C as
Think.
somebody. Somebody. Yep. It's an E or an I, but we'll have to check that. My memory fails me. So one good thing about Silvadene is this. It is also an antimicrobial agent along with a debriding agent. So it removes the dead stuff, for lack of a better word, but it also keeps it cootie free. being antimicrobial. And so that's why it's used a lot. I keep it on hand at home because the gym gets sparked from burning, and then he shows me 3 days later and it's already usually not pretty. So we set that on and he's been in a couple of days. So I think that's why you married a nurse. I don't know why, but maybe because I was just cute. But so it's good because it does both that. And like I said, the antimicrobial idea, and it also debrides it. So it gets rid of that as long as it's keeping an antimicrobial. I'm gonna date myself, but we put it on just like back when we put Noxzema on. It goes on thick. So for those of you, I know some of you are thinking, you're like, what the hell is Noxzema? Noxzema was for acne, but you put it on thick to help your pores, and that's exactly how you put this on. It's thick. You'll put it on with your fingers. Get a sterile tongue compressor. Really is the best thing to do it with. So then there's natural, mechanical, and then of course they can go and get, lack of a better word, scraped in surgery and the surgical debridement. They use the loop effect, and they debride just like they do, similar to regular wounds too. Skin grafting could always be an option if needed. One thing about the emergent care is ABCs, large bore IVs, oxygen, pain management is needed. Also for these patients, bigger the better, for sure. Nutritional support, we know healing has protein, vitamin C for preventing infection. Major issues is pulmonary care. Usually if it's inhaled burn, you look around the mouth and the nares, and it has soot, black soot. But again, that pulse ox could be false. So looking around their nares, looking around their mouth, seeing what they inhaled, it's usually black, and the soot that they've inhaled during those burns themselves. So with ABCs, again, airway, breathing, circulation, the large bores IVs. So not only for pain medication, relief for pain, also for the IV fluid, but keeping them warm. Don't always, please remember to keep them warm, because they're not gonna have the skin for thermoregulation, right? Because it could be initially burned off. So go ahead and read, you guys can read all of that. Rehabilitation phase is what we're moving on to from the emergent. Then we have the intermittent, 48 to 72 hours is the biggest window in that intermittent phase or acute phase. That is not only from what they were exposed to, but what's gonna come later. It's just like we talked about neuro with the swelling. Same kind of idea. Protecting that airway, right? Especially if it was inhaled or electrical, protecting those organs, keeping them on a ECG monitor, monitoring them, so that 48 to 72 hour window post-injury is going to be important for sure. Diagnoses listed there, complications, all self-explanatory. Rehabilitation phase, psychosocial. If they are burned, especially if it was self-inflicted where they poured gasoline and lit themselves on fire, and if they didn't expire because we were able to save them, then they have the body image, body image disturbances. Some of them may also have GI complications too, depending on how bad the burn was per se. So psychosocial, definitely with the rehabilitation. Clothing makes a difference. Constricting clothing for the actual, once it gets, if they are getting skin graft for healing purposes, getting the air to it. Home care instructions, again, can't stress it enough with mental health. And then exercise activity, pain, thermoregulation, all that definitely plays a role. But initially, we have to get that causative agent away from that patient and then take care of the patient from that moment on. So different protocols and policies too, pretty, for the most part, universal, but there could be some special, especially if you work at a facility that has a burn unit. They're gonna have a little bit of different protocols, a little bit more advanced. Questions about any of that?